A lot of the questions that we've been getting have really focused on kind of identifying the trends that you would see when maybe fibrosis is improving in some of the laboratory studies that our primary care doctors get, like, you know, the standard AST, ALT. Like, are there any things that they can follow that could help them at least know that they're doing the right thing and their patient's on the right track?
It's a really good question. I'll say two things about that. One is that improvement in aminotransferases, which is a marker of underlying NASH and inflammation, if somebody is undergoing therapy and they're having weight loss, that is a nice marker, if it's elevated, that we can follow to say that potentially the inflammation pathway is getting better. In terms of the fibrosis pathway, the most important thing that we can look at, honestly, is the risk or development of portal hypertension. And the best poor man's marker that we have, all of us at point of care, is the platelet count. And we talked about this, Dr. Moderator talked about this a little bit in our abnormal LFT talk, but when we, the worst consult that I get is, I get the patient who had elevated LFTs for 6-7 years, and then they normalized their ALT 4 years ago, and everybody felt better about it because their numbers were better. They end up coming to me because they had a picture done from another reason, and now their liver suggests a nodular morphology, and we go and we plot their platelet count in EPIC or your EMR, and you start to see the platelet count just go like this. And now that patient's got cirrhosis. They normalized their ALT and AST because they were actually becoming cirrhotic, not because there was actually an intervention. So there is not a great non-invasive way to monitor for fibrosis, which is why it is, from a laboratory standpoint, why it's really important to look at transient elastography testing to monitor that on a yearly basis, which we do in the fatty liver clinic, or again, in terms of research context or academic medical centers, MRE has a huge role non-invasively for monitoring in this area.
Yeah, I'm happy you brought up Fiberscan, because I think, when you look at these new technologies that are available in the clinic, that people can get to assess this, that these are major advances. Could you expand a little bit about Fiberscan? How do you use it in your practice, and how could the primary care doctors potentially integrate that into their practice, or how should they integrate that in their practice, or should they just send all of these patients to a hepatologist?
That's a great question. We will run out of patient slots if everybody with fatty liver disease is sent to every hepatologist. So I think it is incredibly important, and I think we've seen some great work that has come out recently in the last couple of years in the general medicine literature that have shown the utility of open access to Fibroscan testing and technology for risk stratification in the general population, both primary care, endocrinologists, your patients with diabetes. If you have access through your healthcare system to order a Fibroscan test, which many do, this does not require referral to a specialist. You can order a Fibroscan test on your patient with fatty liver, and you can get that information. And just like me, you can look at the cut points. And if that person meets the threshold for F2 or higher fibrosis based on that cut point, which again, remember, is about 8, that person should then definitely be referred to a gastroenterologist or a hepatologist for further discussion about the risk management, utility of liver biopsy, what else needs to be done in the evaluation. But a huge proportion of patients who have an F0 disease on a Fibroscan absolutely can and should be monitored by all the amazing things that our primaries are already doing, which is aggressive control of diabetes, aggressive control of blood pressure, dyslipidemia, weight loss interventions, all those things.
Great. And, given the fact that there's such a internal medicine slant to this topic and our audience today, there's definitely a lot of questions. And I want to bring us back, and I did this with Priya also, the statins. The statins just become a major issue. I think people are so fearful of statins, their effect on LFTs, and whether or not you can use these with advanced liver disease and cirrhosis. And we talked a little bit about that with Priya, that there might be some data that they're actually good for people with cirrhosis. But what do you do with the statins in these patients? Are you switching them? Is there any safer statin? Well, how do you, use statins or modify statins in your practice?
Yeah, that's a great question. I want to be loud and clear when I say, do not stop a statin in a patient with NASH, okay? There is excellent data in this patient population of, number one, the clinical need for statins in this patient population. Again, cardiovascular related mortality is the leading cause of death in these patients, and that ASCVD risk reduction and the primary prevention from a primary cardiac event in patients who meet criteria for statin indication should absolutely be continued, really regardless of the aminotransferase elevation. Now, there is the caveat when we start to see 5 times the upper limit of normal, and again, 5 times the upper limit of normal. So we're talking, elevations in the multiple hundreds. Then maybe we'll start, we'll do a statin holiday. We'll talk about switching, to a different statin. And the one we see that most commonly with, right, is honestly atorvastatin because of its metabolic pathway. The other statin that I want to say that probably isn't the best statin of choice in this population, especially somebody who has fibrosis or advanced fibrosis, is simvastatin. Again, that statin by far has the highest adverse side effect profile. It has the most liver-related metabolism, and so you're going to have an increased risk of, rhabdomyolysis and muscle injury with that statin. So that's definitely probably not the best one to be using. But the other ones, your rosuvastatins, your pitavastatin, your pravastatins, all those other ones, absolutely no contraindication. And, I think as Priya mentioned too, there are studies that have shown that in NASH and non-NASH that it actually can improve, reduce progression to fibrosis, potentially reduce the risk of development of liver cancer, and in patients with portal hypertension and cirrhosis might actually improve portal pressures.
Great. And then, of course, these questions on almost every topic you'll see this. Supplements. What are the supplements that people could potentially use? I mean, we heard vitamin E. It seems to come in and out of favor in terms of NASH and how we use it. But are there any other, pearls in terms of supplements?
It's a great question. I'm pretty strict about counseling my patients to please don't go to their local nutrition store and buy any liver cleanses. Things that have been studied, turmeric has been studied, not effective. Different probiotics have been studied, also have not been shown to be effective. So while there are things that are probably not harmful per se that have been looked at, they're definitely not efficacious. So outside of high dose vitamin E, and I do want to make the point that we do need to actually counsel on the alpha form of vitamin E, which is actually active form of vitamin E that patients should be using. Sometimes that is available over the counter. Sometimes that does require a prescription from a physician. And if nothing else, I give my patients the prescription for the alpha form, just so that the pharmacist can help them pick out the right bottle of vitamin E that they want to be using. The important thing is you don't want to keep somebody on vitamin E for 10 years because of the long-term risk that we know in epidemiologic studies. So what I do in clinical practice is if I've got somebody who I'm considering vitamin E on, they've got evidence of NASH, they've got elevated aminotransferases, I put them on the vitamin E, we do a trial for a year. If their enzymes are not improving at all, then we stop the drug. If the enzymes are improving, we use that as a biomarker that they're actually having some improvement, and then we consider continuing it for no more than 5 years.
Great. Another one of those medicines that comes up a lot, especially, with this cardiovascular interplay and obesity, is metformin. And what do we do with metformin for this particular patient?
Yeah, that's a great question. So metformin has been studied extensively. Again, with the scope of the talk today, I tried to focus on the things that were newer and that we were looking at, and I unfortunately did not have time to go over the metformin data, which is older. But unfortunately, metformin has not been shown to be efficacious at all in terms of NASH resolution. It has no role in markers of improvement in fibrosis. So while it is an excellent drug for diabetes, has an indication, right, for patients with impaired fasting glucose for primary prevention of diabetes, it does not have a role as a therapeutic for NASH. So we would not recommend that. And given just, again, the change in the ADA guidelines, what we know now about the, the earlier initiation of GLP-1s and SGLT2 inhibitors, we're probably, need to start thinking about, especially in NASH, swinging the pendulum away from metformin use and to more aggressive use of these other injectables and orals.
Anything else like other, things, we hear a lot about coffee, lipoic acid, and these other kind of, what people think are more natural ways to combat liver disease. Any thoughts on any of those?
Yeah, those are great questions. And we could do a whole nother hour on all the, lifestyle interventions, dietary things, sleep, hygiene, all that stuff that has been studied in this disease. Coffee, though, I will mention, is one that actually in epidemiologic studies very consistently, not just for NASH, but for all liver disease, has definitely been shown to reduce the risk for progression to more advanced liver disease by about 30% and reduce the risk for development of de novo HCC by about 40%. So I do personally counsel patients that up to, and this is a crazy amount when you say it out loud, up to 5 cups of coffee a day can potentially reduce your risk. Now, again, these are potentially cardiac patients. You got to be careful of patients with pre-existing atrial fibrillation. You got to warn them about palpitations. There is something about the caffeine coffee interaction, and it has something to do with the phenols and other things in coffee. They've looked at green tea. We don't see this effect with green tea drinkers. You definitely don't see the effect with other caffeinated beverages. And there is an effect with decaf coffee, but it's not nearly as robust as it is with caffeinated. The other counseling thing that's really important is it's black coffee. We don't want them using extra creamer and sugar and other things that are going to add, obviously to their adiposity risks.
Now, one of the things that I find, striking is that effect of bariatric surgery. And when you look at the different types of bariatric surgeries, whether it's the gastric sleeve, endoscopic versus, the balloon placement, and we don't have a session on bariatric endoscopy really during this talk, but there's certainly been this push to do sleeve gastrectomy endoscopically, and there are a whole host of other endoscopic bariatric surgeries. Is it really the weight loss, or is it something about the operation like a gastric bypass that really improves NASH and their risk?
Yeah, this is a great question. I'll start off by saying it's probably both. And I'm extrapolating that right from the literature that we have on the role of, Roux-en-Y gastric bypass, versus, just things that we looked at with the lap band, which we're not even really using anymore, that doesn't obviously have the same metabolic benefits and definitely doesn't have the same effect on magnitude of weight loss as, sort of the gold standard, which is the Roux surgeries. But sleeve, as we know, is really becoming the most common because it sort of is that happy medium between restrictive surgery, but it obviously also has metabolic benefits. And so a lot of the newer literature has really focused on sleeve gastrectomy in this population. And, some may be familiar, even sleeve gastrectomy in well-compensated cirrhosis to reduce likelihood or need for liver transplantation or even improve candidacy for liver transplantation. That's a super hot topic right now. So those things are all really important. We don't recommend lap band anymore in this population. In terms of the bariatric procedures, in terms of balloons and other things, there are some small single-center studies that have, definitely shown some improvement in histology as a result of weight loss, have shown improvements in hemoglobin A1C and lipid parameters and those other things. We don't have any long-term data. So the study I showed you earlier in that long-term bariatric data was really patients who'd gotten Roux-en-Y gastric bypass predominantly.
Great. Yeah, I will tell you that it's remarkable to see those effects with these particular surgeries. And then you just brought up in compensated cirrhosis. So, Child's A, these are people we get very worried about sending for even a gallbladder surgery, which many people think is a very minor surgery. But certainly, you keep that in your mind. But yeah, pretty, the aggressiveness of which we are sending people for surgery, because weight loss is so important in this patient group. So any final comments, any kind of words of wisdom or pearls that we can review on the day 3 recap?
I think in terms of NAFLD and NASH, I think really the thing is this is so prevalent, right? 1 in 4 patients that you're seeing in your primary care clinics have this disease. And if you don't think about it, consider screening for it. And I will say that our guidelines, EASL is already recommending screening for NAFLD in all diabetic patients. I'll tell you that the ASLD guidelines by the end of this year will likely say the same thing. So we're really going to see a huge pendulum shift in terms of screening, which again is going to put, again, a huge burden on our primary care practitioners to think about these pathways for referral, access to Fiberscan, using these non-invasive tests that we talked about, that FIB4 score, that NAFLD fibrosis score, to help you determine which of your patients do you need to have see a gastroenterologist, which of the ones do you need to more aggressively enroll in lifestyle interventions, and then remember to reassess the risk in another 2 to 3 years, because risk is not static, risk changes.
Great. Well, thank you very much. I think this was extremely enlightening, and I think for a primary care audience, focusing on a topic like this, that 1 out of 4 patients that you see in your clinic, this is going to be a major problem in the future unless we really work on getting people, to lead a more healthy lifestyle. And I think this idea of catching people and getting them to lose 10% of their body weight to, revert them back to a normal state is really, really important. And, we've heard that really advice through many different talks this week, and especially my talk on GERD. It doesn't take, 50, 70, 80 pounds of weight loss. Sometimes 10% of the body weight can really have a dramatic improvement in both the metabolic and the anatomic and physiologic stuff in the GI tract.